care managers and the patients, the inpatient care managers did turn over quite a bit. So we put everything together in a guidebook to provide workflows, training resources, job descriptions in the case of some places that didn't have people fitting the description of an inpatient heart failure care manager. We put together a job description so they would know kind of how those people were supposed to work, and then again, competency assessments for each person with a role in the program. One of the key interventions that we felt was important is something we call RealTime Metric, which is actually addressing a problem that we had with our Health Connect, or I guess Epic, I guess as everybody else knows it. The inpatient and outpatient medication list didn't always talk to each other nicely. So what we did was when the home health nurse went to the patient's home, they would call the outpatient heart failure pharmacist care manager. And then they would discuss the medications the patient was supposed to be taking, what they actually had with them at home, and whether or not it matched what we had in the record. So we have all that cleaned up before the patient was seen by the physician at the 7-day visit. So well, we found a lot of issues there where patients would be taking duplicate medications. Maybe one was a brand name and one was a generic, and the patient thought they were 2 different drugs, so they take them both. Or times when they didn't pick up a medication from the pharmacy. One case in particular, I know it's anecdotal, but of a patient who kept being readmitted, and we were increasing and increasing what we thought was a furosemide, and one very astute home health nurse realized that the bottle looked a little strange to her, the furosemide bottle, and she peeled back the label and realized that it was famotidine. So, you know, this kind of error led to the patient being readmitted a lot and feeling like she thought that her diuretic wasn't working, and indeed it was not working. And because she wasn't getting it. And so when she finally was able to get the correct medication, she was able to stay out of the hospital. So these things are things that that do happen, that do lead to our patients coming back. So we felt that this was a very important intervention, especially considering that most of our patients have over 13 medications when they're discharged from the hospital, not including all the vitamins and things like that they take. All right, and another intervention that we added later, but we thought was very important, was using something called the Walther Prognostic Index. It's a tool that actually was published in JAMA in 2001 that predicts the 1-year mortality in the older adult populations after they've been discharged from the hospital. So it's a very simple way of looking at the patient and deciding whether or not they could use an inpatient palliative care consultation. At the time that we put this in place, we didn't have very much referral to the inpatient palliative care team, and this did increase the number of referrals, and 56% of those who did get referred ended up receiving an end-of-life plan. So we felt that that was very helpful. So at this point, I'm going to turn it over to my partner, Dr. Maria Teichner.
Okay, I'm going to just focus on some of the medical interventions that we used to support our program. Just checking here. So very early on in the implementation of our program, we recognized that empowering patients, providing them with some kind of self-management skill or tool was very important in reducing readmission. So very early on, we looked at the flexible diuretic plan, and what this is it is a program that allows education of the patient to identify early signs and symptoms of heart failure, And by educating the patients, they know they have a tool that would help them to empower them to do something to manage their condition. And so with the conjunction with their physician, they were prescribed a dose, an extra dose of diuretic. And if they did not improve, they got a second day of extra diuretic dosing. We found that this did help to reduce some of the readmissions, and so we decided that one of the other efforts is that many of these patients who are newly diagnosed and recently discharged may not feel comfortable with the flexible diuretic plan or may have a number of questions. So they oftentimes would call the after hours KP on call advice nurse. And the advice nurses oftentimes would respond with, referring the patients to the emergency room. So we decided that by providing the flexible diuretic plan as in the form of a smart text and order set that was implemented in our electronic medical records, we were able to allow the nurses to access this information, provide this information to the patient, and then they would send a message on to their care manager for follow-up the next day. So this is one of the earliest tools of empowering patients with self-management skills. Another area that was identified, interestingly, during the course of the Transitions in Care program is we looked at our readmissions and found that there were quite a number of one-day length of stay hospitalizations. Then we looked at our emergency room admissions in our chronic heart failure patients and found that as much as 30 to 50% of our patients that were seen in the emergency room were readmitted. And a significant number had one-day length of stay. So we came to realize that, perhaps if we had better access to an outpatient usage of IV furosemide, we may be able to avoid some of the congestion in the emergency room and even reduce unnecessary hospitalizations. So we standardized some smart sets and order sets across Southern California and all the urgent care areas, as well as in the medical clinics. This allowed the physicians to be able to safely use IV Lasix or IV furosemide in these areas. And it kind of relieved some of the unnecessary emergency room visits and hospitalizations. So we felt that this really helped to reduce readmissions. Based on current trends, we expect a usage of IV furosemide in these other areas to be around 2,500 or greater for the year 2019. Now, I don't have the clinical trial data to show you, but many of you probably are already familiar with the guideline-directed medical therapies that are beneficial in the heart failure patients with reduced ejection fraction. This slide just illustrates the different vasodilators that should be, just part of their background therapy. We found very early on in the rollout of our program that we actually were doing very well in ensuring that this population was on the appropriate vasodilator. That was in conjunction, if you recall, with the JACO-CORE measures that were being looked at for patients hospitalized with this condition. This next slide looks at the doesn't show up on here. It looks at the gamut of different guideline-directed medical therapies, including beta blockers, and the 3 specific beta blockers that are beneficial in the patients with LV dysfunction: carvedilol, metoprolol succinate, and bisoprolol. It illustrates here on this slide the targeted maximum doses that are necessary to achieve the benefits that were seen in clinical trials, and that was for mortality reduction and reduction in readmissions. And then it also illustrates the very far right, the mean daily doses that were achieved in the clinical trials to be able to realize these benefits. So this just illustrates where we have to be able to realize the reduction in readmissions. When we did a deep dive of our population, we found that suboptimal dosing was very much a big problem. And so although we could demonstrate that we were getting patients appropriately on vasodilators and beta blockers, we really were not realizing the maximum benefit because of suboptimal dosing of our patient population. So we provided patient lists to our frontline staff, or heart failure care managers and physicians, on their performance on suboptimal dosing, and increase the knowledge and awareness of this problem, and hope that we're going to see some realized gains with this information. We also looked at, or actually this slide illustrates the relative risk reduction and all-cause mortality across all the different drug therapies available to patients with HFrEF, or heart failure with reduced ejection fraction. What was most compelling to me was the aldosterone antagonists. If you standardize it for a year, you can see here that the numbers needed to treat to save one life is only 18 patients. So we know that nationally the use of this drug is very much underutilized, so we were very interested to see what we were doing across Southern California. The next slide illustrates our aldosterone antagonist usage. In 2018, it was only 22.5%. So this was information that we thought was very compelling, and shared it with our champions, and reviewed the literature, and asked our care managers to really focus on this problem, the underutilization of aldosterone antagonists. So what we have done is provided a tool that provides a list of patients who have aldosterone antagonists missing from their medication list. Okay, what about exercise and cardiac, exercise in this heart failure population? As Dr. Cantor had already reported out, there's definitely benefits in reducing mortality and readmissions, particularly in the patients with reduced ejection fraction. This came out from the Heart Failure Action trial that was published in 2010. And just to illustrate how long it took to implement this, in 2010 was when the clinical trial came out, and somewhere around 2015 we started recognizing that that was going to change the guidelines on their stance on the benefits of exercise in heart failure. And eventually we were addressed this as a priority to increase awareness amongst our providers of the benefits of exercise in this population. The data was presented around in 2015, and we did see an increase in enrollment by 120% by 2017. And about 2018 was when we rolled out the virtual cardiac rehab program that helped to alleviate some of the access issues that we had in the traditional hospital-based cardiac rehab programs. So the expected enrollment at the end of 2019 it's expected that we will enroll over 1,600 patients in some exercise program. Okay, what about diet and its role as a intervention? There is this statewide program that I believe one of the investigators is the Stanford group. They're looking at Medi-Cal population with heart failure, and they're interested in looking at the outcomes when these individuals receive a medically tailored meal. These are free home-delivered meals over the course of 12 weeks. And individuals will also receive individualized nutritional education sessions with a registered dietitian. We began this pilot across Southern California at the end of 2019, and we're still in the process of identifying patients and enrolling them into this program. So, some interesting pilot study is underway. Okay, now what's some of the work that we're looking at in the upstream population? I think the areas of opportunity really lie in continuing to address the suboptimal dosing of patients who really need to benefit from these guideline directed medical therapies, the vasodilators, under usage of the aldosterone antagonists, and then suboptimal dosing with the beta blockers. We're also partnering with our Complete Care program partners in diabetes, hypertension, and CVD to address some of the upstream patient population, better control and follow-up of patients who have uncontrolled hypertension. And then the latest thing many of you may be hearing about are the SGLT2 inhibitors in diabetics with heart failure. We're working with our partners in diabetes to update the guidelines to include diabetics with heart failure, get them on SGLT2 inhibitors where they can benefit with mortality reduction and reduce heart failure hospitalizations. Just to give you some idea of the data, if you, over the course of a year, if you treat 1,000 diabetics with heart failure, the numbers needed to treat is 100 patients, and you would save 25, there's a 25% reduction in heart failure admissions. So really very interesting data. The other clinical trial that was recently published and reported out in the European Society of American Heart is the DAPA-HF trial, which also demonstrates similar trends, similar benefits in the heart failure population without diabetes. So we're looking forward to seeing some changes. We anticipate changes sometime, we hope sometime this year, on including SGLT2 inhibitors as part of the medical treatments for the heart failure population. We're also looking at revisiting remote monitoring. I want to say about 10 years ago, we looked at some remote monitoring technology and piloted it at about 3 medical centers and really did not see any impact in reducing hospitalizations or quality of life in our patient population. But I think part of the problem back then was I don't think we had reliable processes yet. We were still working on ensuring that across the region we had really a standardized model of care that was staffed adequately to address the demand, the volume of patients that were being cared for at each medical center. So I don't think we were really ready with the technology, and the technology then really had some glitches to it. So now we're interested with a more robust program in place and standardized across Southern California. I think we're ready to revisit some of the remote monitoring technology that's out there. So just to summarize, we reviewed what our model of care looks like in this transition model for heart failure population. We reviewed the benefits of real-time reconciliation in the home. The Walther Prognostic Index is a tool to improve identification of patients who would benefit from palliative care. The earlier interventions with a flexible diuretic plan, getting that into the electronic record and supporting our after-hours nurse advice centers, and then improving access to the outpatient diuretic usage in urgent care and medical clinics, we feel has helped to reduce a lot of our readmissions and ER visits. Optimizing the guideline-directed medical therapies, very important in our work for the coming year, and then continuing to promote exercise in our heart failure population. We're looking forward to seeing how the guidelines will change, and we can selectively use SGLT2 inhibitors in the treatment in our heart failure population. And then focusing in on how diet can have an impact on reducing hospitalizations. Thank you.
Thank you so much. Terrific. I wonder if you could run it back to the slightly earlier one. That's it. No, next. That's it. That's great. We can break to groups to discuss in smaller groups each of these presentations that we've had today. But we're doing well on time, and we do have 10 minutes for any questions about different aspects of this heart failure program. And I'd particularly ask those folks who we've been hearing from Kaiser, which is an integrated finance and delivery system, that also has a strong implementation capability. I think we also need to be thinking about it for other populations in other different situations where the financial arguments are maybe less compelling or less easy to make. And also the implementation is perhaps more difficult. But do come forward with some of those questions, or any questions about the implementation of these interventions. I think those are particularly important questions about applying it to other settings and other groups. So, yes, Carol.
Yeah, I just have a question relating to some of, thank you.
This is thinking out of the box. You know, I think it was last year or thereabouts, the study that came out looking at the Medicare penalties for 30-day readmissions that hospitals were being attached to. And then a study that suggested maybe patients weren't getting admitted, they were either being treated as an outpatient or they were sent home and not being admitted, possibly in the background setting, thinking that, you know, a hospital did not want to incur a penalty. I know that the true story is not totally in yet, but do you have any comments about that, or how did you approach that, or did you approach it in any specific way? You obviously have a pretty concerted effort around a lot of the aspects that probably have to do with the readmission. Obviously, your rates went down probably because of that, but any comments?
Well, I think that because we've been very fortunate as an organization, because I think we, you know, we look at the whole process, inpatient, outpatient transitions, and you know, the fact that we're integrated, there's this warm handoff, as well as leveraging our electronic medical records to make sure communication gaps are narrowed. We are able to ensure that patients don't, well, we try to minimize them falling through the cracks, ensuring that they get the follow-up. There are goals of making sure that the patient is seen in a timely fashion, because usually in that first week of discharge, there's so many potential problems that can come up. As you know, part of the presentation was the RealTime Metric and the importance of that, picking up medication errors, empowering patients with survival skills when they're discharged, and making sure they have some kind of support with the after-hours nurse advice. So I think we've been very lucky to have all these other processes already in place. We communicate with each other in many different ways. You saw how complicated the processes are. It hasn't been easy, but you know, these do exist, and I think that we've been very fortunate to have that support the program.
Well, certainly we've had to address the concerns, especially of our cardiologist community, about those articles regarding the potential increase in mortality in the patients who go through